Hello, I'm Dr. Ira Nash. Welcome to Well Said. When most of us hear the word radiation, we think of something potentially dangerous or even out of a science fiction movie. But in the world of cancer treatment, radiation can be a life-saving tool. And thanks to advancing technology, we now have a more precise, targeted way to deliver it, which is proton therapy. Today, we're breaking down what proton therapy is, how it works, and its potential to change how we treat certain cancers. To help us better understand this cutting-edge treatment, we're joined today by Dr. Charles Simone. Dr. Simone is a research professor and the chief medical officer of the New York Proton Center. He is also a member of the Department of Radiation Oncology at Memorial Sloan Kettering Cancer Center. Charles, welcome to Well Said.
Thank you very much for having me. I'm excited to be here.
Before we get into proton therapy specifically, can you give us just kind of a big picture explanation of what radiation therapy is and how it's used in treating cancer?
Radiation therapy is one of the three main pillars of treating cancer, along with surgery and systemic therapy. Systemic therapies being chemotherapy, immunotherapy. But radiation therapy has two main roles in treating cancer. One is to either try to cure or enhance the chance of cure of patients where the disease has not spread far from the original site, or in patients with more advanced disease to help palliate symptoms or prevent symptoms from forming. Radiation can be very effective as a local therapy akin to surgery without having an operation, where we can target local areas with traditionally X-ray or photon radiation therapy, and we'll talk about protons as well, but target a focal area and really shrink tumors significantly in many cases to help either shrink the tumor, control the tumor long-term, or improve symptoms that the tumor may have been causing.
So before we get into the proton therapy, I have another sort of general question about radiation therapy in general. Some of our listeners may be familiar with the idea that radiation can actually cause cancer or can be dangerous. And so can you just briefly explain that apparent paradox?
So we are all exposed to radiation in our daily life, whether it's taking a flight, whether it's certain foods we ingest, whether it's environmental exposures, and high levels of radiation through environmental or other exposure have been linked to risk of cancer. Now, that risk is very low, of course, but that can contribute to cancer. We think about what are the main causes of cancer, and we think of genetics, of course. Much of it is actually diet-related or lifestyle-related, smoking, alcohol use, etc. But a small subset is related to radiation exposure. That's when you're essentially giving radiation ingested or the entire body is exposed to a source of radiation. Here, with therapeutic radiation, we're using a much higher dose of radiation, but in a much more controlled environment than an exposure to radiation across the whole body, where we're just targeting a small focal area, and with the intention of directly depositing the radiation in the tumor to kill the tumor. Yes, it can damage normal tissue as well, and there can be side effects from it, a very uncommon one of which is a cause of a second cancer. That's typically very rare, on the order of 1% of patients or less, and usually 10, 20, 30 years down the road after delivery of the therapeutic treatment. So usually the benefits of radiation in the immediate setting far outweigh a small chance of a secondary cancer a long time down the road.
Okay. So you're an expert in a particular kind of radiation treatment called proton therapy. Can you distinguish proton therapy from the more, conventional forms of radiation treatment?
With traditional radiation, which are X-rays, just like getting a chest X-ray, they travel through your body, and that's, if you think of an image, how you get an exposure to be able to have that image on an X-ray. With therapeutic radiation, it's a much higher dose of radiation than a regular X-ray is, but it's the same concept that the radiation goes in, leaves the head of the machine, goes into the body, travels to the tumor, hits the tumor and treats the tumor, but then travels through the other side. There's nothing that stops the radiation. They're electromagnetic waves. They lose energy as they travel through the body, but they don't have a distinct stopping point. So you can kind of think of it as regular radiation goes through and through the body.
Okay.
With proton therapy, because they're a charged particle, they have a finite range, meaning they deposit most of their energy at a specific depth that we can control. So the analogous to photons, they leave the head of the machine, they travel into the body, they hit the target, the tumor, but then all the radiation gets deposited at the tumor. And so all of the normal tissues beyond the tumor are completely protected and are not exposed to that radiation. And that's where you may see a reduction in side effects, better preservation of quality of life, and to your earlier question, a reduction in risk of secondary cancers because all of those normal tissues are now completely protected from getting exposed to the radiation.
Without getting too technical, can you explain the difference in the technology that generates the X-rays or the photons in conventional radiation versus the machinery required to generate the protons in this other form of radiation therapy that you're talking about?
It's pretty dramatic difference, quite frankly. Traditional radiation, the X-ray photon radiation, is delivered with a linear accelerator. That typically is a machine that fits in a modest size. You can think of it like an office room. Mm-hmm. And the machine itself, it plugs into the wall. You do original commissioning to make sure it's safe. And then you treat patients with it. You kind of never think about it again. It's on autopilot. That machine generates its own radiation, delivers its own radiation. Here with proton therapy at the New York Proton Center, we use a cyclotron that accelerates particles 2/3 of the speed of light at negative 425 degrees Fahrenheit. From there, that cyclotron, the radiation gets sent into treatment rooms. And the treatment rooms, as opposed to about a 10-foot tall machine, we have gantries that are 3 stories tall. They rotate 1 story above and 1 story below the patient. And each of those gantries are about 300 tons with millimeter precision delivers the radiation into the treatment room. So very different scale of technology needed to deliver the proton therapy.
Yeah, I mean, when you said cyclotron, my thoughts went to like these particle accelerators that physicists use to probe the insides of atoms and fundamental nature of matter. Is that the same kind of thing that you're talking about?
It exactly is. There are 2 main ways to deliver and accelerate protons. One is a cyclotron, one is a synchrotron, and essentially both of them, just like what you described, they're nuclear accelerators, yes.
What you described sounds like not just large and sophisticated, but really expensive. Could you speak a little bit to what it takes to create the kinds of machinery that you're talking about?
The upfront cost of proton therapy is more than traditional radiation, as you can imagine, with that technology. The other is the continuing cost of protons, because the machine's essentially 24 hours a day, since there's so many more moving parts than a regular radiation machine. We have engineers on site and our physics team to be able to do preventative maintenance and other work on the machine. So certainly the cost of delivering protons is more than traditional radiation. I will say that cost has come down a good bit over time as proton therapy has become much more standardized and much more widely utilized, and there are more vendors in the space of proton therapy now. To give you a sense, when I first started using proton therapy at my former institution, University of Pennsylvania, we came online in 2010. At that time, there were only 5 proton centers in the country. Now there are 49, so there are a good number more and several more in development over the last decade and a half. And many of the newer rooms, newer proton centers, are just a single treatment room. So you have a much smaller scale than, for instance, here at the New York Proton Center, we have 4 clinical rooms to treat patients, and the building is just dedicated purely to proton therapy, taking up a city block by about a half an avenue here in Manhattan.
Wow.
But cost is coming down, but I will say cost is not quite the whole story, because yes, it costs more to deliver proton therapy, but there are several studies that have shown because proton therapy can reduce toxicity, because proton therapy can prevent patients needing to be hospitalized or other effects, protons are actually, in many cases, very cost-effective at reducing the overall cost that patients both have and their insurance companies pay for them.
So I hope we get into that a little bit. I just want to ask a few more questions about the technology, and then we can talk about the clinical application. You mentioned before that the major difference in proton therapy versus conventional radiation therapy is that you can adjust very precisely the location and the depth inside of somebody's area to which these protons are directed. Is that just a matter of focusing the beam and dialing up and down the energy so that you know how deep the protons penetrate?
Yeah, exactly right. We essentially can use different energies to leave the head of the machine, and different energies will be deposited in different parts of the body. And because it's a charged particle coming out of proton therapy, if you remember kind of the middle school or high school biology, we can now use magnets and other ways to within a millimeter or two, deposit the radiation according to the energy in an exact spot.
What happens when that energy is delivered? What does it actually do at the level of the tumor?
Yeah, and that is very similar between protons and traditional photon radiation therapy. Radiation therapy generally works by forming double-stranded DNA breaks. So we cause DNA damage that causes breaks in the DNA of the cancer itself, and then the cancer either dies directly from that, or when the cancer tries to divide, it dies because it's not capable of doing so. So it can lead to cell death. When we deliver very, very high doses of radiation, whether it's with protons or traditional radiation, we actually can ablate the tumor completely and don't rely on damaging the DNA. So you can almost think of it akin to surgery. It's actually called radiosurgery. It's like you're having surgery without an operation, but same mechanism of action between protons and regular radiation.
So you're delivering so much energy in such a tiny space that it actually sort of burns up the tumor? Is that a reasonable way to think of it?
Yeah, you could think about it exactly right. Like we're almost like surgery cauterizing something. We're completely burning it up inside.
So we've talked a little bit about the technology. What does this look like from a patient's perspective? So if somebody were getting treatment at your facility, walk us through what that looks like.
Patients lie down generally on their back, but sometimes on their stomach or even their side. But most of the patients lie on their back. We immobilize them pretty thoroughly here. Protons, as you can imagine, if the radiation's stopping at an exact depth, with a millimeter accuracy, we need the patient to be very reproducible from one day to the next. So we generally have a beanbag device around them, or we put them in some other type of mobilization device where they can't really wiggle or move around on the treatment table. We watch them, we monitor them throughout the treatment, we talk back and forth, the patient and the therapist actually delivering the radiation, but we have them in a way that they're very reproducible for the treatment. Then the machine rotates around them and the radiation comes out and treats them. They can't see the radiation, they can't feel it. The only way they actually know they're getting treated is there's a little clicking noise that some patients can say they hear. But outside of that, it's almost like you're laying on a table getting a CT scan essentially, but without going through a donut. It's an open table and the machine just rotates around you.
And how long does a typical treatment take?
Really depends on the size of the area we're treating and what area and how much dose, but in general, each beam of radiation takes a minute to 3 minutes, and patients are typically getting between 2 and 5 beams. So the actual treatment delivery is generally on the order of around 8 or 10 minutes, and they're in the treatment room for about 30 minutes. That includes coming into the room, getting you in the exact right position, lining the patients up, getting them in that mobilization device that I mentioned, taking an image of them to verify the positioning, and then actually treating, all in about 30 minutes.
Is this a repetitive kind of treatment? I know for typical radiation therapy, patients go for 5 sessions or 20 sessions or something like that. What is the proton beam protocol like?
Most of the treatments are every day, Monday through Friday, for several weeks, typically 4 weeks, 5 weeks. We have a good portion of patients that we treat with what's called stereotactic body radiation therapy or stereotactic brain radiation therapy with protons. About 12% of all the patients that we treat get that, and that is treatment in just a couple of days, typically 1 to 5 treatment days, as opposed to several weeks, Monday through Friday. So it can be a little bit of a mix. What we've seen and reported on and published on is generally patients can tolerate proton therapy better, can have fewer side effects for many conditions, and so that enables us to do 2 things. One, we could either more fully treat the tumor, and obviously that can have benefits as far as tumor control and survival. We can lower side effects, or we can actually treat to a higher dose per day without increasing the risk of side effects. And treating to a higher dose per day, one, makes it more convenient for patients because they come in fewer treatment times, especially patients that are traveling from out of town to come in to get proton therapy. But there may actually be biological advantages to killing the tumor more effectively by delivering higher doses per day with the treatment. So each treatment's a little bit different, but we really are actually the leaders in doing these high doses of treatment at the New York Proton Center with proton therapy.
What are the most common kinds of cancers or types of tumors that you're treating now?
Yeah, we really treat all solid malignancies. The most common ones that we treat are head and neck tumors. They generally have a very high acute and subacute toxicity profile with traditional radiation therapy, so we can help to minimize side effects there. Brain tumors, of course, patients are always at risk and worried about neurocognitive problems after radiation that we can help to potentially decrease the chance of or eliminate altogether. Lung tumors, those patients have a lot of trouble swallowing, trouble breathing, hospitalization rates that we can also reduce the chances of. And then the other two big populations are breast cancer patients that have positive lymph nodes, particularly women with left-sided disease where with traditional radiation to treat those lymph nodes, the radiation is going right into the heart. But with proton therapy, we can prevent that dose of going into the heart and minimizing any long-term risk of heart problems. And then the last big group that we treat is pediatric patients. We treat quite a number of children here at the New York Proton Center, about half or more of all kids with solid tumors in the city. And that's really because these kids are particularly susceptible to long-term late complications from regular radiation as they're still growing and developing. And proton therapy can help to avoid those complications.
You mentioned a whole range of conditions. I imagine many of those, if not all those, were and continue to be treated with conventional radiation therapy as well. How do you and other experts in this field determine whether somebody should get conventional radiation therapy or proton therapy?
That's a great question, and that's, I think, actually an important one where you really want to go to providers that have the experience and have all their tools available to them. If you only go to a center that delivers photon therapy or only go to a center that has any affiliation with proton therapy, that answer may be made for you just by nature of how the radiation oncologist that you saw.
Sure.
You had mentioned earlier in the call that I'm an expert in proton therapy, but I also have leadership roles in many photon therapy societies, and I look at proton therapy as another tool in my chest, and I look at each individual patient and say which radiation modality can benefit them the most. Typically what we see is patients that have the biggest benefits from proton therapy are in patients that have the highest risk of complications, whether it's an acute complication right during or immediately after treatment or a long-term complication, such as the children growing or the secondary cancer risk that you mentioned before. So high toxicity rates with regular radiation, a lot of those side effects can be mitigated or prevented completely with proton therapy. And then the other big group of patients is patients that unfortunately, some tumors we do better than others, and so tumors that have poor tumor control rates with regular radiation, where we're not controlling the tumor quite as well, those patients can also often benefit from proton therapy because we can more fully treat the tumor without causing more side effects, or we could even escalate the radiation dose to the tumor without causing more side effects because of proton sparing the normal tissues. So those patients can really benefit the most. And so, many cancers are adequately treated and have very effectively treated with traditional photon therapy, but some of the higher risk cancers may really benefit. And that could be, I just mentioned a few cancers, the common ones that we treat, but many, for instance, prostate cancers are very adequately treated with photons, but we see many patients, and that could be specific anatomy of an individual, where protons can be a big benefit and reduce the chance of long-term rectal or other complications. So it really is an individualized decision for each individual patient that we review.
You mentioned throughout our conversation some significant potential advantages to proton therapy. What's the evidence that these potential advantages are real, that they are making a difference in terms of clinical outcomes or complication rates and survival rates, that sort of thing?
If we know that the upfront cost of proton therapy is higher, we really want to know that there's a true value, not just that there's a hypothetical less normal tissues are exposed. Now, we actually have a lot of data now. Early on, as protons were new, even though they're more than 30 years FDA approved, but as there were few centers at the time, there was not a lot of large randomized multi-center experiences comparing protons and photons. So most of the data that we had early on was single center reports where proton therapy, the toxicity profiles were better than that institution had achieved with traditional radiation therapy. But now we're starting to see several randomized trials have been published or reported all in the last 2 or so years, where, for instance, for esophageal cancer, a reduction in a whole host of complications, or patients with ophthalmopharyngeal central nervous system disease where there's better survival. So we're starting to see head and neck oropharyngeal cancer, the most common type of head and neck cancer, both a reduction in side effects as well as better survival when compared in randomized trials, multi-center trials between protons and photons. There are quite a number of other trials that are either ongoing or that recently finished, and we're waiting for data to mature, whether it's in lung cancer, liver cancer, prostate cancer, et cetera. So we'll have more and more sense. And the answer is not going to be that, just because, for instance, the esophageal cancer or the oropharynx cancer trial said that protons are better, doesn't mean that every esophageal or every oropharyngeal cancer patient has a benefit. It just means that we need to understand which subsets of patients had the biggest benefit. But it's encouraging to see that we have this comparative and randomized data already showing a support for proton therapy.
And are there certain patient profiles or tumors for whom proton therapy is not a good idea, where it's contraindicated?
Typically with hematologic cancers, both protons and photons, we don't treat a lot of. Those cancers are generally better served with systemic therapy. For any local cancer, protons can be considered. But again, it's the tumors where we have exceptional tumor control rates and very low toxicity rates with regular radiation. You really aren't going to see an appreciable improvement with proton therapy for those cancers. Again, it's a little bit of a broad, I can't say every, for instance, prostate versus lung versus, even within each cancer, there are different risk groupings and stages. The more locally advanced type tumors generally are the ones that benefit the most. Very, very early stage tumors generally can be adequately treated with traditional radiation therapy.
You also mentioned the fact that people have to be immobilized to take full advantage of the spatial focus of proton therapy. There are lots of parts of the body that are pretty actively moving. People breathe, the heart pumps blood. How do you get around those sorts of issues?
Some proton centers, for that very reason, don't treat a lot of lung cancer or upper GI cancers because of the concerns that if the radiation is stopping at an exact millimeter, but that area is moving because of the reasons that you mentioned, they just don't have a lot of certainty about where that radiation dose is stopping. For all of our patients that are treated with in the thorax or the upper abdomen, where we see respiratory motion, we actually do what's called a 4-dimensional planning scan, where we not just monitor all the traditional 3 dimensions, but we actually monitor the breathing and where all the internal organs go during the normal respiratory cycle, and we take that into account with our planning. Same with heartbeat, that we take that into account with our treatment planning as well. We try to, if the motion is significant, we will try to mitigate the motion, whether that's we actually compress the breathing a little bit by putting a little band on the upper abdomen so patients don't take quite as deep of a breath, and we monitor how that affects where the normal organs and the tumor are in the body. Or we actually, in some cases, a minority of cases, but we have patients actually do breath hold, and we treat them while they're holding their breath, and while they're breathing and breathing in, we have the machine stop. So we have a lot of tools at our disposal. We really have terrific confidence in being able to treat these tumors and opening up an avenue where the lung cancer patients, esophageal patients, the upper GI, liver especially patients, they can be very, very effectively treated, and we know exactly where all the organs are at all times during that motion.
You mentioned earlier that there's been a substantial growth in the number of proton centers around the country, but the number you cited, I think it was 49, is still pretty small compared to the number of available, I'll say, traditional or conventional radiation therapy centers. How does that affect the accessibility of the therapy that you're talking about?
It still does, for sure. We published this many years ago, but we did an analysis of geospatial disparities in access to proton therapy. We published it in 2021. Several new proton centers have opened since, but we showed that in the U.S., the median travel time to get to a proton center was over 1.6 hours. So, a big disparity. Certainly, most of the proton centers are congregated in cities. In fact, most of the NCI-designated comprehensive cancer centers at this point have access to proton therapy. Those centers tend to be in cities more than rural or non-city areas. But obviously, the United States is a big country. There's still huge pockets that don't have access to proton therapy. As we see the cost of protons have come down, and as we see more single-room centers that are, of course, cheaper than a bigger center like we have, those are starting to be in community sites to much more frequency. And that's, I think, helping to limit this. But there still is a scarcity of resources. We certainly need more proton centers. Right now, only about 2% of all cancers that get external radiation are treated with proton therapy.
And where do you see this field going, beyond just the diffusion of the technology to more places geographically and maybe as a result the cost decreasing? But for the technology itself, what do you see coming in the future?
We'll see more centers, there'll be more access, the cost will come down. I think we'll see more use of what's called hypofractionated radiation, the higher dose treatment that we do a lot of here in New York, but many proton centers don't have the same comfort yet. But I think that will help with disparities and maybe also tumor control for many disease sites. And then there are some really neat things on the horizon. Proton therapy may couple very well with immunotherapy. Immunotherapy, as some of your listeners may know, is a very hot way to treat a variety of tumors across solid and non-solid malignancies, and has either replaced or been a complement relative to chemotherapy in some disease sites. Proton therapy may be a better way to combine radiation therapy with immunotherapy, and we know that a lot of what we do in radiation oncology is not in isolation. We do it in combination with surgery or with systemic therapy. As we're combining these modalities, there's more risk to patients, more side effects. But if we can have better synergy with the immune system because we're not irradiating marrow-producing organs, there may be a benefit to that. The other thing that I think is very exciting is something that some listeners may be aware of, something called flash radiation therapy, which is, as opposed to delivering radiation every day, Monday through Friday, for several weeks, and each day, as I mentioned, 8 minutes, 10 minutes, this is delivering an entire course of radiation in just a single day in less than a single second. So it's Wow. called flash, aptly for how quickly it's delivered. But the why it's so exciting is, one, it certainly can help with disparities if people are traveling over an hour to get to a proton center, and now you only need 1 day as opposed to 5 weeks. But the other is in the preclinical data that we have, flash may actually protect normal tissues to a much better degree than even traditional proton therapy can. And right now, the only way to deliver flash deep in the body, other than for skin targets, is to use proton therapy and the accelerators that we talked about, the cyclotrons that we talked about earlier in the call. So, I think we're going to see a lot more investigation into the use of proton flash therapy. 2 small human clinical trials have recently been completed, and now we're starting to think through trials in curative populations. And this may, if it pans out in protecting normal tissues, really be a game changer, not just in radiation oncology and proton therapy, but all of oncology.
So let me bring us back to the patient perspective here as we're heading towards our wrap-up. For somebody who's gotten a recent cancer diagnosis or has a loved one who has a recent cancer diagnosis, should they be asking their physicians about proton therapy? And if so, how do they start that conversation?
I do think it's a good idea. And, I will say I am the first, and many of my colleagues feel the same regardless of being in protons or photons, but I always encourage patients to get a second opinion. I want them to be comfortable. I want them to hear the options that are available to them. I think there are some cancers, like pediatric cancers, where the radiation oncologist will readily send them to us at a proton center to protect the children from late complications. Another patient population we haven't talked about today, but that's a huge patient group that is sent to us at a proton center, is patients getting re-irradiation, meaning they've had radiation once, and now the cancer has recurred. Those patients, generally, a photon center can't safely retreat them, or at least to a high enough dose to control the tumor without causing significant side effects, because the body never really forgets that it had that prior radiation. So those patients, they can come to the proton center, they can get treated more effectively in the retreatment setting and get offered a new chance at cure. And so we see other radiation oncologists will readily send those patients as well. There's probably big groups of patients that could benefit that other radiation oncologists wouldn't readily think to send. And so I do think asking your radiation oncologist, your medical oncologist about proton therapy can always be good. And they may have a very good reason why it may not be needed, but it may also be that they didn't think that you were aware of the technology, that you would be interested in potentially traveling to a proton center. So without asking those questions, it won't be on their radar to discuss it with you in many cases.
Yeah, well, that makes sense. And in terms of getting that basic knowledge so that you can have those conversations with your physicians and other caregivers, where would you recommend people turn to get more information about what we've been talking about today?
There are a lot of great sites. The National Cancer Institute has information that's very good for cancer. Mayo Clinic as well. OncoLink, which was started at the University of Pennsylvania, is the oldest large-scale information site and has a lot of information specifically on proton therapy. So that's another great site as well. Sites that are done by academic centers or the government are great. The NCCN guidelines. This is guidelines developed by comprehensive cancer centers designated by the NCI coming together to make recommendations. And those recommendations are very technical for providers to follow, but they also have patient versions that you can see. And the guidelines will say, for a specific cancer, proton therapy should be delivered, or proton therapy could be considered, and that could also be another source as well.
And where would people find those?
Public domain. It's free to patients. NCCN is the acronym National Comprehensive Cancer Network, so nccn.org.
Great. All right. Well, thank you so much for educating us today.
My pleasure. Thank you so much for having me.
My guest has been Dr. Charles Simone. He is a research professor and the chief medical officer of the New York Proton Center and a member of the Department of Radiation Oncology at Memorial Sloan Kettering Cancer Center. Thanks also to our editor, Edward Lee, to our producer, Lois Bentavenia, and our audio engineer, John Mullen. For more information about this particular episode and to find all of our past episodes, please visit our website at medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are also welcome to send their comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.